If I'm starting recording, you can see my screen, is it? Screen kanamo. Hello? Okay. Today what we will discuss is MCQ based on the immunology of immunization 1. അതായത് നമ്മളെ type of immunity and basis of how immunization works. That's a very fundamental. Therefore, you might think that I know everything about it. You should know 99% of it. If 1% you don't know, it is better that we revise it. I don't know whether all of you have seen it. Therefore, types of immunity, base of immunization works. Many of the questions will look very simple. Therefore, answer immediately as it goes. What is the definition of immunization? Can you read it, one of you, from the library? Fast. Hello? Hello, can you read it?
What is the
Yeah.
immunization? A, the act of introducing a vaccine into the body. B, a process by which a person becomes protected against a disease, generally through vaccination. C, the production of memory B cells. D, the development of passive immunity.
Which is it? Quick answer. Huh? Which is the answer?
Development of
ഏതാ നിങ്ങൾ ഏതാ പറഞ്ഞേ? Immunization is a process by which a person becomes protected against a disease, generally through vaccination. In which other way can you get protected? In which other way can you get protected other than getting a vaccine?
If the disease is already
Yeah,
infected.
Diseases, you may have subclinical diseases, you may have the disease itself, but majority of time the disease may not. Now, suppose you have a diphtheria case in the ward, okay? Suppose you have a typhoid case in the ward, you cure him. Do you have to immunize him against him? Fundamental question. You have a typhoid, you cured him, he came with perforation, surgery was done, you treated him, you're discharging him. The patient asks, should I take typhoid vaccine or not? You are the person discharging. You're calling the consultant says no need. Suppose there's a diphtheria, you're discharging. You discharge, will you give diphtheria vaccination or not? If he's not given vaccination before. Am I asking very complicated case? Huh? Well, why all of you are silent? Am I talking to postgraduate doctors? Hello? Gopika Parayao, Gopika, can you answer to that?
Yes.
Will you give or will you not give? It's not. Huh?
Yes, sir. Will give.
Will
Will give.
Is it scientifically correct? You see, you must have the habit of reading your books. Let me tell you bluntly this. You must read whoever teaches you whatever subjects is passive knowledge. Active knowledge is very important. You must read your book. This will strike you. Diphtheria, you have to give the immunization when he goes home. Typhoid also, if I remember rightly, Nelson has written, when you discharge the patient, you must give typhoid vaccine. Therefore, remember this very clearly. But generally, diseases produce long-term immunity. In fact, if you get measles, there is enough proof that you have lifelong immunity. If you take measles immunization, children who have taken immunization, many have developed measles again, but subclinical. Anyway, I think this you should have known. Vaccination, can you read it now, Faris?
Vaccination, it is the act of introducing a vaccine into the body to stimulate the immune system to induce a protection against infection or disease. Immunization, it is the process by which a person becomes protected against a disease, generally through vaccination.
Therefore, immunization generally through vaccination, but as it's slightly different, you might get immunized by what you call by the disease itself. That's what it is. You may become immune by the disease. Next question.
Which type of immunity
Yeah.
long lasting due to formation of memory cells?
Active immunity.
Active
Fast.
immunity.
It shouldn't take much time. See, active immunity. Read it.
Active immunity is acquired through natural infection or immunization and is long lasting, as it generally leads to development of memory cells.
Okay. What is the next question?
What is the primary function of humoral immunity?
Quick. Which is the answer? These are undergraduate questions, huh?
Extracellular microbes.
Defense against extracellular microbes and the toxins.
Very good. Defense against extracellular microbes and toxin. Intracellular is usually associated with cell-mediated immunity. Okay. Read it now.
Humoral immunity is conferred by B lymphocytes, which is a principal defense mechanism against extracellular microbes and their toxins.
Okay.
Which antibody class is most abundant in serum and play a major role in secondary immune response? IgG.
IG. Which the correct?
GG.
Okay, correct. The primary is IgM, secondary it becomes IgG. Okay. And so you're right. What's the next question?
What is the main source of passive immunity in neonates?
Maternal antibodies.
Yes, what's the answer?
Maternal.
Very good. Paternal antibody. I'm going through fast because these are simple questions to make you happy, you know. You know the thing. It's question 6, I removed question 7. Go ahead.
How long it takes for a peak IgG antibody titer to appear after primary immunization with an inactivated vaccine?
6 weeks. No, 4 weeks.
4 weeks.
Yeah, 4 weeks. That's why when you give any DPT today, you don't repeat the same vaccine within the next 4 weeks because we don't want successive waves of antibodies to interfere yourself. To kill the vaccine, the interval is 4 weeks. Okay, so is the live vaccine, but we'll come to that later. Therefore, 4 weeks minimum period between two doses of the same killed vaccine. But if you give DPT today, you can give another killed vaccine tomorrow. That doesn't matter. Okay. Therefore, this is what it is. Okay?
Primary
Yeah. Yeah. Tell me.
In primary immune response, IgG antibody titer increases up to a peak value usually reaches 4 weeks after immunization.
Very good. This is what it is. You have, sorry, there is some option. Wait a minute, add option. Hidden. All right. Now this is this diagram. We will keep on coming again and again to the same thing. The thing is that I don't know this. 1 minute. Let me see. Add options. It's not seen here. I don't know why it is not coming up. Anyway, this is the primary response. You have the initial exposure. The initial antigen exposure elicits an extrafollicular response that results in very rapid appearance of low antibody titers. And as B cells proliferate in germinal centers and differentiate into plasma cells, increase up to a peak level. Therefore, there's a lag period, number one. Then it goes into a very peak in 4 weeks time. That is 2. That is 2. And then usually reach 4 weeks after immunization. The short lifespan of these plasma cells, because the peak is pointed, short half-life plasma cells results in rapid decline on the antibody titers, which eventually returns to baseline. How much is the time they have not written? Month, but usually I think within 6 months it returns. That is called the what you call the primary immune response, and this is usually IgM. Remember this, there's a lag period of 10 days, shoots up, and then comes the next response. Long-lived plasma cells that have reached survival niche in the bone marrow continue to produce antigen which decline in slower kinetics. Now, this we are talking about the secondary immune response. You would find that there is no lag period. It rises within 7 days. It peaks. Here it's and it has a broader base, but it also declines. You understand? Then, if there is memory B cells, if there is secondary cells in the bone marrow, it comes and produces antibodies. Therefore, the level remains at a longer time. This is called the correlation of antibody to various phases of the vaccine. Podkin's disease results in rapid. It is better that you know it well, which eventually return to baseline. Therefore, this we will come to that again and again, again and again. The questions will come because this is one of the fundamental bases of immunology of immunization. The days, the time, the primary being IgM, secondary being where it is closed, etc. Now we will come back to the next question. Can you read it?
Which type of vaccine induces the strongest and the most sustained antibody response?
Yeah.
Right.
Live attenuated.
Yeah, live attenuated
Live.
vaccine produces the strongest and the most sustained antibody response because it mimics a natural infection. And what happens is it keeps on multiplying in your body. Therefore, it produces the primary and the secondary response. And therefore, in our times, it was told no booster doses required for live vaccines. What are the live vaccines we are giving, Majida? What are the live vaccines we are giving in our practice?
Polio.
Yeah.
Rota.
Okay. They are oral live vaccine. More important, parental.
MMR.
Yeah, MR is what is given in government service. MMR is what is given in the private institution. And somebody said varicella. Yes, varicella. What would you like to give to your father? If you want to give 10,000 rupees per herpes zoster, which if you are concerned about your parents, better give him herpes zoster vaccine. Therefore, but the funny thing is live attenuated vaccine is supposed to be very effective, but the problem is we tend to give live attenuated vaccine booster doses. Why? MR we give at 9 months, then we give one at 15 months, and somebody says give at school entry. Varicella also 2 doses. Why like that? Anyway, we'll come to that later. Okay, read the answer.
Live vaccines are superior, exceptions BCG and OPV, to protein antigens, which in turn are superior to polysaccharide vaccines.
Now, why did we say BCG? BCG, is a kill vaccine which is effective against. It may not prevent the infection. It may not prevent even pulmonary tuberculosis, but complications are very, very less. BCG, we will talk each vaccine later. Which is better, OPV or IPV now? If you have a preference to give OPV or IPV, which would you prefer? Where is Mohsin today? Mohsin didn't
IPV.
Mohsin and
Yes.
are there. Mohsin, which did you give to your child? ഇവിടെ ഉണ്ട് പക്ഷെ കാര്യം പറ. Which vaccine you gave your child?
IPV and OPV.
Both together. That's the right way to go about it. We will discuss it later. Which is better, OPV or IPV? IPV. In our times, it was OPV. From the preventive medicine times onwards, we used to write OPV, OPV, OPV. But there are many issues which will come up. One of the most important is it is an oral vaccine, and many times it's not taken up. It doesn't produce the immunity. That is the reason they said. But we will discuss it later. Now, read what is given inside that red column, please.
Type of vaccine. Broadly speaking, live vaccines are superior, except BCG OPV, to protein antigens, which in turn are superior to polysaccharide vaccines. Live versus inactivated. Higher intensity of innate response, higher antigen content following replications, and more prolonged antigen persistence generally result into higher antibody response to live than inactivated vaccines. Protein versus polysaccharide re- recruitment of T cells helps and induces induction of GCs
What is
result
GC?
in
Amal, what is GC? Gonococcus?
Then
germinal cells.
What's it?
Germinal cell.
Germinal cell.
Okay, germinal center. Because last time I think Gopika was reading. That's the first and last time she read, I think. Okay. Into higher antibody response to protein or glyco than to polysaccharide. This is the most important thing. Life is supposed to be superior. Protein conjugated vaccines are superior to polysaccharide vaccine. You must know the fundamental reason because conjugated protein stimulate the germinal centers. We will come into beautiful and live vaccine. They keep on multiplying in the body. They are there. Therefore, they produce the primary and the secondary response with a single dose. Now, what's the can you read?
What is the minimum interval between two doses of inactivated vaccine, except rabies?
What's the minimum interval?
4 weeks.
4 weeks. We have already said that the primary response, the antibody level is highest at 4 weeks. We don't want that, successive. This will again produce the antibody. We don't want any interference. Therefore, it is 4 weeks between the same dose. Remember that. Two inactivated, when the interval between dose of inactivated vaccine means same vaccine, DPT. But if you are giving some other vaccine, you can give it. Okay. Read it.
Reference: the minimum interval between two doses of inactivated vaccine is usually 4 weeks. Exception is rabies.
Why is there an exceptional rabies? We will try to find out. I tried to find out, I couldn't make out. What exactly is the immunological basis by which you are giving a cell culture grown? It's considered a dead virus vaccine in repeated intervals. What's the immunological base? I couldn't find out. But anyway, now read only what is given inside the bracket. Okay. Can you read?
In
Yeah.
primary doses, a minimum interval of 4 weeks between primary doses allows the development of successive waves of antigen-specific primary response without interference. Interval before boosting, a minimum interval of 4 months between primary and boosting allows affinity maturation of the memory B cell and thus higher secondary responses.
Okay. Now, if you are giving the last dose, that is a booster. Sometimes it is for us, booster is when you give pneumococcal vaccine, as we are doing in the health in our hospital, 6, 4, and 6 weeks, 10 weeks, and 14 weeks, and then we are giving the booster of 1.5 years. The last dose of the 1.5 year that becomes the booster. In the government service, when you are giving a dose at 6 weeks, 14 weeks, and 9 months, 9 months becomes the booster. Therefore, the last dose is booster is given to boost the effect of priming and boosting allows affinity maturation cells of the memory cells. Therefore, between the actually it should not be 4 weeks, 4 months, sorry, 4 months. Actually, they say good would be 6 months. Minimum is 4 months between the last dose. Now, what happens is when you are giving just 2 doses, the second dose acts as the booster. Many places it will be written as 8 weeks. Anyway, whatever it is, this now please understand one thing. that the majority of the facts which I have written, I have taken it from the Purple Book of IAP Guidebook, which you should buy, you should have it, you should read through it. And if you are not doing it, at least go through the PowerPoint presentation which I have done for you. And these are all getting recorded. Now remember this, what's the interval between the recommendation of spacing of vaccine? What is the spacing of vaccine? Just see, can you read it? This is very important.
Excuse me, sir.
Antigen
Padmanabhan, sir.
combination.
Yeah, who is it?
It is Anju, sir.
Anju, tell me.
Sorry for interfering, sir.
No problem. Very good.
Sir, actually, the minimum interval between 4 weeks, that is for live attenuated vaccines, no, sir? Because inactivated vaccines, we usually is equivalent to killed vaccines, no?
Yeah,
So killed and
inactivated.
inactivated. So the previous question we just discussed, I think, sir, the question was, what was the minimum interval between two inactivated vaccines? Can you just go
Yeah, it is
back, sir?
actually 2 doses of inactivated vaccine. The same vaccine. You understood that?
But inactivated vaccines are killed dose.
See,
Okay, 2 doses of the same inactivated
yeah,
vaccines.
yeah.
Okay,
Suppose
fine.
you see somebody
Fine, I
comes
got
and
it.
says, Doctor, there is a point in that also. Somebody comes, gives a DPT today, and they come back and tell you, look, I'm going to Gulf. I would like to take it before that. Can I take it before the 4 weeks? You can take it up to 4 days before the 4 weeks, inactivated vaccines. If you are taking 5 days before, it is not calculated. Live vaccine
Got
minimum.
it, sir. Thank you, sir.
Minimum has to be 4 weeks. With live vaccine, you cannot have an interval less than 4 weeks. Anyway, now read through this, please. Recommendation of spacing. Can you read? Paris?
അടുത്ത slides. Antigen combination recommended interval between doses. 2 or more inactivated vaccine may be administered or at any interval between the doses. Inactivated and live vaccine may be administered or at any interval between doses. 2 or more live parenteral vaccine may be administered on the same day or at an interval of at least 28 days. Pneumococcal conjugated vaccine.
Okay, carry on.
And pneumococcal conjugated vaccine PCV13 and Menactra in children with functional anatomic aspleen or of anatomic asplenia should not be administered at the same visit. Separate these vaccine by at least 4 weeks and administer PCV first.
Okay, why is it that we will come to in the discussion later on meningococcal vaccine? That's something which we are not normally giving meningococcal vaccine, but it's something which you should advise them. Now, meningococcal vaccine, will you talk about meningococcal vaccine to your patients? Have you ever talked about it? Have you ever seen any of our consultants talk about it? Gopika? Hello?
No.
No.
No, sir.
Do you think
No,
it is?
sir.
Do you think it is required?
Yes, sir.
Yes, sir.
Yeah. Therefore, who said yes? Let me ask now. The Mohsen, did you give to your child? Hello.
Okay.
Hello.
No, sir.
No, sir. Therefore, should you be giving or not be giving? My question is simple. See, there are certain diseases which are very, very rare. It was not that uncommon when we were in SAT hospital in pediatrics. We used to get a meningococcal disease either dying or coming in shock or meningococcemia almost once every month, and sometimes epidemic did occur. And we used to sit with the patient with adrenaline trip and all that. Now I understand it's rare, but epidemics do happen. But remember, always talk to to your patients. Give them the option. No patient, if it can knock off a well child, absolutely well adult, it can knock off in hours. So when the patient comes to know that his child was under your care, developed there is a vaccine available in the private sector, and you never talked about it to them, they will never ever, be happy about it, and they'll be very unhappy about it. Therefore, remember, talk about all vaccines which are available, though it is very rare. Remember, meningococcal vaccine we will discuss later. You should talk about it. Herpes zoster, human papilloma virus. Talk about it to all the girls who come about 9 years and document it, because these are they're very important. You may have one case in your lifetime, one patient, but that anger which he shows to you will be understandable. Now, remember here, there is one thing here which you should understand, that two or more inactivated, same vaccine. Say, I again repeat that. Inactivated and live vaccine you can give. Today I gave my MMR. Today I gave DPT or something. The mother did not have time, money for MMR vaccine. He can come and take it tomorrow, no problem. Live parental vaccine should not be administered at the same time. Live parent, say for two or more live parental may be administered at an interval of at least 80 days on the same day. You can give MMR today morning and varicella in the evening. They are telling that in that. But you should not administer it next day. If you give MMR today, you have to give varicella after 28 days. Now, the other thing is regarding OPV. Oral vaccine, it doesn't affect. Therefore, OPV and rotavirus can be given at any interval as per our recommendation. Now, AAP, American Academy of Pediatrics, will not talk about it because they are not giving oral polio. Please remember, the European Society of Gastroenterology and Hepatology, they don't advise OPV and rotavirus to be given together. They don't allow, they don't say this is not correct because the multiplication of one virus will produce interferon and etc. and will prevent the other virus. But as far as we are concerned, OPV and rotavirus can be given together. Okay. Now, can you go ahead now?
Why do polysaccharide vaccine do not induce strong memory B cell responses?
Okay.
They lack continuous.
What is it? Non-memory B cells. What is it? Give the answer fast.
T cell independent antigen.
They are T cell independent antigens. Okay. Okay. Read it now, the answer.
Polysaccharide antigens are T cell independent antigen, as polysaccharide antigen do not induce germinal centers. Bona fide memory B cells are not elicited.
Bona fide memory B cells are not elicited. We'll come to that later. Okay.
What is the phenomenon where repeated administration of a polysaccharide vaccine result in diminished antibody response is called desensitization?
Anybody wants to, any difference of opinion? Amal did not attend yesterday's
Intolerance.
Huh?
Intolerance.
Intolerance.
Who said immune tolerance?
Last semester.
Lasima. Lasima did not attend last time. Somebody read all the Gopika is there. Anyway, all of you went wrong. The answer is
Yes.
okay. Go to this very important one.
Hyperresponsive.
Go ahead.
Revaccination with certain bacterial polysaccharide antigens may even induce lower antibody response than the first immunization, a phenomenon referred to as hyperresponsiveness.
Okay, which is the polysaccharide vaccine which we are giving now? Typhoid, yes, it is. I don't know whether it's available in the market, but we have the conjugate vaccine. Therefore, you should be giving the conjugate vaccine. which is a polysaccharide vaccine, which we give. We don't give any polysaccharide vaccine except one in special circumstances. Which is that? Which we as pediatricians do is supposed to advise. Gopika? Huh? Amal?
Pneumococcal vaccine.
Yeah, pneumococcal, what is that? Pneumococcal polysaccharide vaccine, what's the number?
20.
Amal?
30.
PCB 23, PCB 13 is what we give. Good, you didn't get you went and appeared in Madras, is it not? Where did you appear practicum?
23, sir.
PCB 23. And which type of patient we are supposed to give? Immunosuppressed patient. See, please remember this. You are pediatricians. Which patients? They will not ask you the immunization schedule. Even the mini in our OPD will know the immunization schedule. But you should know special things, everything about immunization. And PP 23, you should advise to which patient which you might see when, especially a hematological disorder. Amal, my God, how did you appear? You would have failed if you had got a sickle cell anemia. One of the most important things in sickle cell anemia is to give at 2 years a pneumococcal polysaccharide vaccine 23. And will you repeat it? Will be the question. If you don't answer the first thing, the second will not come. And normally some people say repeat it at 5 years, but the general answer is don't repeat it. Similarly, where else do you give? Suppose you give adult immunization. Adult immunization is now 3 vaccines basically, 3 or 4. One is PCV 13 you are supposed to give. After 4 weeks or 8 weeks or something, you have to give pneumococcal vaccine 23. But it will not produce lifelong immunity, but you are not supposed to repeat it. Not supposed to repeat it only once, because the second dose will cause less pneumococcal vaccine, less dose antibodies. This is a very important phenomenon, hyper-responsiveness. And you are supposed to give everybody like me are supposed to take flu vaccine every year. This is adult immunization, which pediatricians may not be asked, but there's often a topic of discussion. So hyper-responsiveness is the answer to it. You give more doses, the antibody response will become less. Okay, read it now. Given in the purple book. Okay. Can you read it? Hello?
Revaccination with n bacterial polysaccharide. Immune response to vaccines. Reactivation with certain bacterial polysaccharide or of which groups C. meningococcus is a prototype which even induce lower antibody response than the first immunization, a phenomenon known as hyporesponsiveness.
Okay. Has anything come up? Due to this phenomenon?
Due to this
Yeah.
only a single booster of either pneumococcal or meningococcal polysaccharide vaccine is recommended, even in patients who require lifelong protection.
Okay, remember this very carefully. He has written booster. Either a single booster they have written. Actually, it's actually a single dose, I thought. Remember, this is all given in purple I'd get book. Therefore, if they ask you, will you give a booster? It becomes a little tricky. But in purple book, they have written single booster. 1 dose, 2 doses, that means. But actually, it is 1 dose. Anyway, we'll come to that later. Okay. Fast. Can you read?
Where do long-lived plasma cells primarily reside after germinal center reaction?
Okay. I thought you will answer it. Gopika, I think you read it last time. My God. See, I'm putting it in PowerPoint. I'm putting it in the YouTube, asking you to see it. You are not bothering to read it. And these are fundamental immunology. And you're not answering it. This may not be very important question, but pneumococcal vaccine was a fundamental question. How can you be a pediatrician without knowing why you shouldn't give booster doses for pneumococcal vaccines? Pneumococcal polysaccharide vaccine. Here, of course, remember the answer. Okay.
Bone marrow.
Yeah.
A few plasma cell exits for spleen and may migrate to survival niches, mostly located in the bone marrow.
Okay. Now, the next diagram that comes, I will keep coming back at the every moment. I had put it up in the last moment. I will, because I thought you would go through it. See, here what we have said is the last sentence, which I have highlighted at the end of the GC reaction. Now I will explain the whole diagram. You don't seem to know it. I told you this is one fundamental diagram, which you should know, which is I have taken it from Potkins. A modified form of it and not in color is given in IAP guidebook. Potkins is the master vaccination, which costs only about 10,000 rupees books. The 8th edition has come. I got a PDF of the 7th edition. That's why. Remember, this is, I'll go step by step. Here, the antigen enters the lymph node or the spleen. This is the lymph node or the spleen it enters. And what happens? The antigen is immediately, the antigen produces the B cells becomes activated. The lymphocytes become activated. They produce the plasma cells. The plasma cells produce the primary response is low levels of IgG antibody. They go into the blood level. They are not specific. They go into the, I can make you read this, but then it will take a lot of time. You should go home and read it carefully. Therefore, this is low levels of plasma. Now these B cells which produce plasma cells, these B cells should now enter into the germinal center of the lymph node. This is the germinal center of the lymph node and spleen. For this, it requires T helper cells. Therefore, this is what T cell, only if you have conjugate protein or live vaccine will it enter. Polysaccharide vaccine will go through this. It will go straight into the lower levels of low affinity IgG antibodies. Once it comes into the germinal center produces, it takes about 4 to 6 weeks. In fact, it takes about 4 months to 6 months to produce large amount of IgG, huge amount of IgG, which are specific. And they migrate into the blood, and some of them go into the bone marrow and remain as a nick. Therefore, they produce large amount of IgG. This is, for this, it requires dendritic cells. It requires T cell follicular help cell. T follicular helper cell is required inside the germinal center. Outside the T helper cell is required. It produces large amount. This happens only in conjugate protein and T cell dependent protein. Here, what is not shown is along with the antibody, memory cells are also produced. The memory cells go into the blood. We will show in the next diagram, come back and stay in the lamina of the spleen and the liver, which stays as the memory cell. So this is the basis of germinal response to protein antigen. They have not told about the memory cells. These things I have to read. If I read too much, time will go. We are only in slide number 20 of 50. The question MCQ is 20 already. We are reaching almost 1 hour. Therefore, I'll go ahead. Remember this, go back and read it very carefully. This is the heart of the germ center that happens. Okay. Now here comes a little controversial question. Go ahead. Can you read?
Which route of administration is Which route of administration is preferred for non-live vaccine due to high
dendritic cells present? Dendritic cells are the cells which first attract the antigens, dendritic cells, which is a preferred route for non-live killed vaccine.
Intradermal.
Hello, carry on.
Intradermal.
Yeah, I would not say it is wrong, but we'll come to that later. Okay, now this is in one question. In question number 13 in a MCQ book, they have written the intramuscular. I will discuss about it is preferred over the subcutaneous route. Agreed. Subcutaneous agreed. Now the next question is
Which route of vaccine administration recruits the highest number of dermal dendritic cells?
this is question 27. I mixed it to make you understand certain. Sometimes the MCQs, the right hand doesn't know what the left hand says, and it can be controversial. See, the MCQs are the best way of testing. There's no doubt about it. But the problem is a one way. If the questioner makes a mistake, you cannot ask him back. Yeah, what is he asking? Which is a vaccine? The last time we said, we said intramuscular preferred route over subcutaneous route, high DC presence. Here, intradermal is there and he is giving intramuscular. That automatically means that it has more dendritic cells than intradermal. The next question, what should be the answer? It should have been intramuscular, but he has given intradermal route of action, recruits the abundant DCs in the skin. Now we will discuss it a little. That is important. Where are we giving intradermal doses, doctor? Which are the vaccines which we are giving intradermal?
Rabies.
Rabies,
BCG.
IP.
BCG. Yes,
IPV.
BCG is what is given routinely as intradermal. Yes. Then IPV in the polio virus. But there's some controversy regarding it. And why are we giving IPV and rabies intradermally rather than intramuscularly? I discussed this in this. If you are giving IPV in your clinic, in your hospital, which way route will you prefer? Intradermal or IM? Why is the government insisting on an intradermal dose? Was that well? Let's read the literature first. Can you read what is highlighted? What is in the inside that bracket? Read it. Hello. Can you see?
Yes.
Kandile.
Secondly, the site of administration of killed vaccine is of importance. The intramuscular route, IM route, which is well vascularized and has a large number of patrolling dendritic cells, is preferred over the subcutaneous route. Intradermal route recruits.
Yeah.
Intradermal route recruits the abundant dendritic cells in the skin and offers advantage of antigen sparing and early and effective protection, but the geometric mean titers are lower than that achieved with IM may be way faster.
Last sentence.
The site of administration is usually of little significance for live vaccines.
So remember, we only want to produce a virus inside the body. It should multiply, but we don't want it to be killed immediately. Therefore, you can give live vaccine anywhere. Intradermal route advantage, antigen sparing. You may have to give only 1/10 the dose. But remember what is written in the purple book of immunization. Antigen sparing effective, but the geometrical mean titers are lower than achieved with IM and may wane faster. Therefore, they are given a small hint here. But we are advising, therefore, what happens when you go to this one and all, they would say intradermal dose is better because 1/10 the dose is required, more dendritic cells are there. That's what all government doctors will be forced to say because that's the government policy. Therefore, can we give intradermally rabies vaccine? Yes, it is well accepted, but remember this. Therefore, we have the option of giving. Now, will you give IPV intradermally? My question, let's about IPV in private practice. I asked this question last time also. Once you open the vial, it's a multi-dose vial. I think it is 5 doses. In private practice, naturally, you can't give it to multiple people. Therefore, give it IM better in the private practice. Keep in your mind that it is intradermal is definitely effective dendritic cells 1/10 the dose, but the geometrical mean titers are lower than achieved by IM. It's written in our purple book of immunization. Now, if you want further, read carefully what is written in Potkin's vaccine textbook. This is from where the Indian Academy of Pediatrics copies and pastes some of the information. Please read carefully. Okay. Read the whole thing. Hello.
First step of immunization.
വന്നിട്ടില്ല.
കാനഡയിൽ നിന്ന് വരാൻ സമയമെടുക്കും.
Their site and route of administration are rare, thus more important. The high number of dendritic cells in the dermis allows a marked reduction, example tenfold, of the antigen dose with intradermal immunization. This advantage of dermal dendritic cell concentration is applied to the prevention of rabies in many countries and could prove useful against additional targets as novel microneedle and needle-free device become available for intradermal administration. Patrolling dendritic cells are also numerous in well-vascularized muscle, which is the preferred route of injection for non-live vaccine. They are fewer in adipose tissues such that subcutaneous injection may be less effective than intramuscular injection under condition of limited immunogenicity as demonstrated for adult immunization against hepatitis B.
Anyway, therefore, this is very clear. Very clear is that whether the IM is better than intradermal or intradermal is better than IM they are talking in between. They say that disease is 10-fold less dose is enough. But then normally I think they give for 5 children. That means they are giving 1/5 the dose. Go to the immunization clinic and find out how they are giving polio in our hospital. Gopika, how are they giving IPV in our hospital? IM. Whenever you go to a private clinic, try to give it IM because intradermal is difficult. Because if it becomes subcutaneous, it has no effect. And remember this, I am making a very controversial statement. 12 or 13 children have died in 2025 after rabies vaccination. There is a point here. Is it because we are giving it intradermal? Many factors may be responsible. And in discussions, people have started telling, why don't you give it IM? But the point is that they don't want to talk about it because it's a national policy. If you talk about it, you'll be thrown out of the government service. Therefore, government doctors, even if they come to IAP, will not talk about it, and IAP has no guts to discuss it. Let me be very clear in that. Therefore, plus, please understand, when you give it to your own patients, what is given in the previous one is very important. This intradermal recruits abundant dendritic cells in the skin and offers advantage of antigen sparing and early effective protection. But that but is very important. The geometrical mean titers are lower than achieved with IM and may wane faster. I also, even in the purple book, they will not say whether you should give it in private IM or IV, but they say because anyway you will be wasting the rest of the doses, give IM. But also when you look at the what is given in the in a book, it's a purple book itself, they would say for immunosuppressed patients, intradermal route is not advised. Why? What does it mean? That the IM dose is definitely superior. But for that, they would say that there are no studies in immunosuppressed patients. That is why we are not advising it. Reading in between lines and reading on the lines of the purple book, I would definitely say that giving the full dose of IM especially in rabies, which is a life and death issue. Remember that. In rabies, it's a life and death issue. And when we have so many failures, I would go in for IM dose. After reading the basic immunology. Anyway, now my question is subcutaneous. Do you give any dose subcutaneous? Any vaccine subcutaneous?
MMR.
No, I didn't understand. Which one?
MMR J's.
Yeah, MMR. See, remember this, MMR and JE are given as subcutaneous doses because they are live vaccines. Live vaccines, we are not interested in the virus being engulfed and taken to the lymph node and the antibodies being produced. No, you give it in the subcutaneous, the virus multiplies, it goes by the bloodstream everywhere. Let it go everywhere over time, multiple lymph nodes. We want it to multiply in the body. Okay, now let's go to the next question. Can you see it?
No, sir. Sir.
What is the primary determinant of the affinity maturation of antibodies?
Affinity maturation means the antibodies become specific to the antigen you're giving. Hello, carry on. I have just,
Yeah.
uh,
Germinal center reaction.
okay, germinal center reaction. I just now said when it enters the antigen, enters the germinal center, two things happen. The IgG antibodies which are produced are numerous, and also they have clonal selection and then affinity maturation. They are more towards the particular antigen. The primary vaccination, when it is not entering the germinal center, low level antibody and they are not affinity maturation. Read it now. Yeah.
The development of germinal center reaction requires a couple of weeks, control the intensity of B cell differentiation into the cells.
That's why the booster dose is given after 4 months minimum. Okay.
What is the key reason why booster doses are required for the disease like diphtheria and tetanus?
Amal, why it is not required for hepatitis B and A? It is required for diphtheria, tetanus, but etc. Which one? My God, after teaching you so well, so much, Dr. Anandam says I am injecting you like a nursery school student with ready-made tablets, but still you are not answering. What is it?
Lack of memory cells.
Lack of memory B cells. Gopika? Read the answer.
Disease that have incubation periods shorter than this period, such as H influenza B, tetanus, diphtheria, require regular booster.
Read what is given in that. Yeah. What is given in the bracket? It has not come. Okay, can you read it? As a slightly, yeah.
Activation of immune memory and generation of protective antibodies usually takes 4 to 7 days. Disease that have incubation period shorter than this period, such as H influenza B, tetanus, diphtheria, pertussis, and meningococcus, require regular booster to maintain protective antibody levels. However, disease such as hepatitis A and hepatitis B do not need regular booster as their long incubation period of this disease allows for activation of the immune memories.
Once you develop the cells, it is a race between the microorganism and your immune system. The immune system, if it has only been not, it has not come into contact, the innate immunity will fight, but that is very, very deficient. Now, when you have the active immunity, if you have been immunized, you have the memory B cells ready for it. But the memory B cells also take 4 to 7 days. If any disease in which the incubation period is less than that, you will have to have ready-made antibodies available in the body. And that can be available only if you give regular booster dose. You give a booster, the antibodies may be there for 4 or 5 years. After that, it starts waning. Therefore, in conditions like diphtheria, pertussis, meningococcus, tetanus, etc., regular boosters are required. When the incubation is long, period is long, like hepatitis B, the hepatitis B comes, the memory B cells become active within 7 days, then immediately it is gone. Now, this is the next diagram. I think is going to take, as it's shown up in here, I will explain it to you. Can you see the diagram? Hello, are you seeing anything? Has the slide changed?
Sir.
Okay. Now here we talked about the same thing, the antigen, the entering the germinal center. Last time we talked about high level of antibodies, affinity, high affinity towards the antigen being produced in the germinal center. At the same time, I told you that the germinal center also produces memory B cells. They go into the blood and they come back and into the periphery of the lymph node as well as the spleen, where they remain as memory B cells. And once the second time the antigen comes, these B cells don't have to enter the germinal center because this will take 2 or 3 weeks. Here, from the memory B cells, straight will produce secondary immune response. But even that will take 4 to 7 days. Therefore, patient diseases which have a shorter incubation, this is the fastest ready memory B cells, but it takes 4 to 7 days for it to act. Therefore, if you want to protect against disease which has an incubation period less than 4 to 7 days, like diphtheria, like rabies, like tetanus, you have to have booster doses. This is the reason why when you have severe injury of tetanus, to prevent tetanus, even if you are immunized, you give passive antibodies immediately. And similarly in grade 3, in class 3 exposure and rabies also, you have to give monoclonal antibodies, rabies immunoglobulin, because the incubation period of rabies can be as short as 3 to 6 days, or maybe as long as 2 years, and sometimes even up to 5 years they have reported rabies. But it can be very short, very, very variable. In the case of tetanus, is rare to be short as less than 1 week, but because it is a life-threatening event, you try to give the immunoglobulin. Therefore, that is why short incubation period, regular boosters required for immunization. Okay, now this is what happens. I think here it is given here. Primary response peak comes only in 30 days. Here the secondary response, there is no lag. There's no lag, it peaks. But even it peaks at 7th day. Remember this. You can see this. Even the second immune response, the peak is the 7th day. It is not, and remember, this peak is not just above this. This well above the graph. It is about 100 times above the graph. Therefore, secondary immune response also very good, but it takes 7 days. Therefore, when the incubation period is less than that, it will not be effective. Okay, now read through it fast.
Which of the following is not a component of passive immunity?
Okay.
Memory B cell.
Okay, that's correct. Passive immunity is, can you read the answer?
Passive immunity is conferred by maternal antibodies or immunoglobulin preparation.
Yeah, that's why we give passive. I already said why we give passive. Okay, can you read the next question?
What is the primary limitation of polysaccharide vaccine in children under 2 years of the age? Lack of adjuvant. Lack of adjuvant.
Uniformity ആണോ? Okay. See, it is in the marginal zones where the antibody is produced. Can you read this? Okay, read it.
Polysaccharide antigens are unable to evoke an immune response in those aged less than 2 years due to immaturity of the marginal zone.
It is in the marginal zone of the lymph node and the spleen that it acts, that the polysaccharide, the antigen primary response is obtained. The antigen does not enter the germinal center. For that, it requires T cell help, which polysaccharide cannot. Therefore, that is the reason these marginal zones are not well developed. That's why below 2 years, you don't give polysaccharide vaccine. Okay? Now read this. Yeah, this is written again from Purple Book only. Okay? Can you read it?
വന്നിട്ടില്ല sir.
Mario. ഭയങ്കര lag period. There's a lag period for it to come. Yeah. I'm sorry there's a lag period because recording people will get irritated because there is a break in our recording. Because can you read it now?
Additionally, polysaccharide antigens are unable to evoke an immune response in those aged less than 2 years due to immaturity of the marginal zone.
Please remember these are slides. This is slide number 33 of 105 of this vaccine, which I've sent it to you. You are supposed to read every sentence of it. This is the whole slide is about polysaccharide antigen bacteria. Therefore, they can ask you a short note on immune response to polysaccharide antigen and conjugated antigen, the difference. Therefore, the marginal zone becomes very important. And if you look at this, I don't know whether the diagram has it come on the picture. Has the slide changed for you?
No, sir.
Say yes when it is. This is a big problem because it's irritating for the person who looks at the via YouTube. Has it changed now?
Yes, sir.
Okay, now what do you find? This is what happens in the spleen. If the antigen enters B cells, plasma cells, IgM, IgA, then it 4 is what? When they survive few weeks or months secreting low levels of globulin, IgM, IgG, or IgA antibodies. That's all. What is missing? The germinal center is missing. Therefore, they remember marginal zone, what you call of the outside. Therefore, because this zone is not properly developed, the polysaccharide antigen are not even able to produce a weak response. Also, they are not able to see this. I can read it out. The B cells use this. Can you read out the what is given in that? Yes.
Extrafollicular B cell response to polysaccharide antigens. B cell use their specific immunoglobulin surface receptor to bind to the repetitive structures of the polysaccharide, reaching the marginal zone of the spleen or nodes. In the absence of antigen-specific T cell help, B cells are activated, proliferate, and differentiate in plasma cell without undergoing affinity maturation in the germinal centers.
Okay.
These plasma cells migrate towards red pulp of the spleen, where they survive for a few weeks or months, secreting low levels of low affinity immunoglobulin, IgM, IgG, or IgA antibodies.
Okay, this is the basis of polysaccharide antigens. Okay, now the basis why it is conjugated with a protein so that they can enter the germinal center. Now, next question. Has it changed for
Which
you?
cells
Yeah.
Which cells provide help to B cell during the germinal center reaction?
Quick.
Follicular helper T cell.
We have a bunch of very intelligent. Huh?
Follicular helper T cell.
Okay, read it.
In the germinal center, B cell receive additional signals from follicular T cells.
Has a slight change for you?
No, sir.
The problem is whenever I put up a diagram, it takes some time for it. We are going back into the same diagram again and again. Changed?
Yes. Yes,
See,
sir.
here is the follicular dendritic cells. Therefore, the answer is initiating the germinal center reaction in GCs. B cell receive additional signal from follicular T helper undergo massive clonal proliferation, means specific to the antigen. Switch from IgM towards IgG, IgA or IgE, undergo affinity maturation. All these words are very important. Follicular dendritic cells. Okay. Next. Read it.
What is the purpose of adjuvants in the vaccine?
Okay.
To enhance adaptive immune activation.
Enhance immune, adapt immune. Okay. Carry on. Read it.
Adjuvants improve immune response to inactivated vaccine by either modulation of the antigen delivery and persistence and enhancement of T helper cell responses.
Read it. That's from the purple book again. Okay. Read it. What's in the bracket? Changed? Okay. Can you see it now?
Adjuvants improve immune response to inactivated vaccine by either modulation of the antigen delivery and persistence, depot or slow release formulation, or enhancement of T helper cell responses. Immunomodulator, which may support or limit antibody responses. Thus, less amount of active ingredient per dose is required for an immune response similar to vaccine without an adjuvant. However, adjuvant may cause some side effect.
Adjuvants may sometimes cause side effect. Anyway, leave it now. Can you read? Please read.
Slide മാറിയില്ല.
തളർന്നു പോയി പോകുന്നു slide. I don't know. It becomes more and more, I think it's taking a longer time. Okay.
Which vaccine-induced immune response provides sterilizing immunity?
What is sterilizing immunity? Navarna, what do you mean by that? And which one does it provide? Quick. There is a controversy. You see, what is sterilizing immunity means when you give it in the body, the surface itself does not allow you to. This normally when I give an injection, the body, the organism multiplies in the body. Suppose I am immune, and suppose tomorrow I get a typhoid, it just goes into the intestine, multiplies there, and tries to enter the bloodstream. At that particular point of time, the antibody will. But sterilizing means it should not allow the organism to even multiply. The initial contact itself, it should not be allowed. What's the advantage? Suppose in the nasal mucosa, pneumococci is there. You are given pneumococcal vaccine. It allows the organism to multiply if it allows it to multiply in the nose, but does not allow it to enter the bloodstream, the patient is protected. But what happens in the community, it spreads from one to the other person. That, according to them, remember, what is the answer?
Live oral or nasal vaccine induce serum IgA and secretory IgA, which also help limit viral shedding on mucosal surface.
This is the basis of which oral polio, we are still continuing to give what is called as pulse polio, the national immunization days. The WHO wants to give the oral polio very much. Now it is less effective for that particular patient than IPV because it prevents the multiplication of the organism. It prevents the wild virus from multiplying in the organism, and it sterilizes that our gut. Similarly, you have nasal vaccines, which we give when you give influenza vaccine, I think is available, which might local IgA antibody. Therefore, according to this answer, inactivated viruses, whatever be it, are not effective in sterilizing immunity. Now read this one. There's this little complicated is this. Okay, read through it. It's taking too much time actually. Okay. Mario.
B lymphocytes secrete antibodies that act by neutralization, complement activation, or by promoting opsonophagocytosis, which result in early reduction of pathogen load and clearance of extracellular pathogens. Humoral antibodies prevent colonization, being the first step in the pathogenesis by encapsulated organisms such as Haemophilus influenzae type B, pneumococcal, meningococcal, and organisms such as diphtheria and pertussis.
The human antibodies prevent colonization, also they are telling. But according to this, we'll go to the next. This is from Podkins. Little controversial, but you can read it. I don't know why it's taking so much time.
Under most circumstances, the inactivated vaccine do not elicit sufficiently high and sustained antibody titers on the mucosal surface to prevent local infection. It is only after having infected mucosal surface that pathogens encounter vaccine-induced IgG serum antibodies that neutralize virus, activate the complement cascade, and limit their multiplication and spread, preventing tissue damage and thus clinical disease.
What it says is that inactivated vaccine do not elicit high sufficient antibody titers, and first it does infect the nasal mucosa. What it means, nasal mucosa or the colon or the gut, and therefore they multiply. They do not produce sterilizing immunity. Now that's given in Podkins. Then read through the what has the slide changed for you?
No, sir.
Therefore, what it means is when the slide changes, you start reading. What it means is, according to them, inactivated viruses, inactivated vaccines do not produce enough antibodies to act on the local surface. Especially pneumococcal vaccine I give conjugated, it does not produce enough antibodies so that it prevents colonization of the nasal mucosa. If it doesn't prevent colonization of the nasal mucosa, the other people in the family will not be infected. This is very important because this is not true. Once you once you immunize your child, actually the person who's most protected is the grandfather. He plays with the child. The chance of him getting pneumococcal meningitis or pneumococcal pneumonia is much less. But they say it doesn't affect. But now it would have changed for you. Read what is in the bracket. Changed?
Yes.
My God, why is it taking so much time?
Current vaccine mostly mediate protection through the induction of highly specific IgG serum antibodies. Live oral or nasal vaccines such as rotavirus, oral polio, nasal influenza, or cholera vaccine induce serum IgA and secretory IgA, which also help limit viral shedding on mucosal surfaces.
Okay. I'll read through the next one, but it'll save time. The neutralization of pathogens of mucosal surfaces is mainly achieved by the translation of vaccine-induced serum IgG antibodies. Neutralization requires IgG antibody concentration to be of sufficient affinity and abundance to result in a protective antibody titers in saliva or mucosal secretion. As a rule, such responses, now the final answer he gives is something very funny. As a rule, such responses are not elicited by polysaccharide bacterial vaccine, but achieved by glycoconjugate vaccines, which may prevent nasopharyngeal colonization or non-bacteremic pneumonia in addition to invasive diseases. I think your slide, if it changes, this is what I read from the next slide. He gives the opposite. He says it is only the polysaccharide vaccine that does not protect. The conjugate vaccine may, but can be achieved by glycoconjugate vaccine. Therefore, there's a difference of opinion even in Plotkin skin. Generally, sterilizing antibodies, very important because we want to protect the community, are produced by live oral vaccines, local vaccines like polio, nasal influenza, etc. Not produced by definitely not produced by the polysaccharide vaccine, but some books do say that conjugate proteins does produce. Did the slide change for you?
Yes, sir.
Okay, I'll go to the next slide. Can you go to that? Therefore, that you keep in mind when a question is asked, better say that the viral vaccine act, conjugate vaccine, you can leave the answer. Okay.
What is the typical lag phase of the primary immune response? 5 to 7 days.
Okay.
5 to 7 days.
10 days. Okay, read it.
When an antigen is introduced for the first time, the immune response starts after a lag of 10 days or so.
What is the lag period for the secondary immune response? There's no lag period. Read this now. Okay, and the slide has changed. Can you read it? Okay, I'll read it out for you. When an antigen is introduced for the first time, the immune reaction starts after a lag period of 10 days or so. This is called the primary response. Now, secondary immune response starts subsequent exposure to the same antigen. There's no lag phase. There's no lag phase. Has the slide changed for you? Response after immunization starts in less than 7 days, persists for a long time, mainly IgG type with high antibody titers. Did the slide change for you?
Yes, sir.
Okay. Now,
secondary
immune response.
Secondary immune.
Read it. Okay.
Secondary immune responses start on subsequent exposure boosted to the same antigen, but there is no lag phase. Response after immunization start in less than 7 days, persist for a long time, mainly IgG type with high antibody titer.
That's what this diagram has come or not come. I can't explain without the diagram.
No, it comes.
To take a time, it's worth waiting for it because okay, now the lag period is this period where it peaks. You understand? Slowly the antibody is rising. 10th day starts peaking. And the maximum is 30th day. Therefore, the lag period, what they're saying is stage 1 here. Here, there's no lag period. Secondary immune response state starts peaking. Therefore, that's why they say there's no second lag period in it. That's why even if you have read through the book and answer the MCQ immediately, you will get into some trouble. Okay. Read through it now.
Which type of the immunity is generated by maternal IgG transfer occurs through IgG transfer across the placenta?
Okay.
Natural passive.
Natural passive. Okay. Yeah, you're right. Read the answer.
Passive immunity is conferred by the maternal antibodies or immunoglobulin preparations.
Now, can you read the next question?
Which immunoglobulin is predominantly produced in the early phase of a primary immune response, IgM?
Okay.
The antibody response sets in 2 to 4 weeks following immunization and is predominantly IgM.
Okay, sorry.
What is the mechanism?
Okay.
What is the mechanism by which vaccine prevent invasive disease caused by encapsulated bacteria? All of the above.
Okay, you must remember this neutralization of toxin, option of phagocytis, complement activation. Okay. Read the answer.
B lymphocytes secrete antibodies that act by neutralization, complement activation, and or by promoting option of phagocytosis.
Read what is given in this one. I'll start reading. B lymphocytes secrete antibody that act by neutralization, complement activation, or by promoting organophagocytosis. This is from the IEP guidebook itself, which results in early reduction of pathogen load and clearance of extracellular pathogens. Human antibody prevent colonization, being the first step by pathogenesis by encapsulated organisms like influenza, pneumococcal, meningococcal, and organisms as diphtheria and pertussis. This is the problem. They give two things. It's like these antibodies, they prevent colonization also, they have written. But the fact of the matter is they say that the IgG antibody is not in very high level that can prevent local antigens, bacteria to multiply. Only when they multiply and they enter the bloodstream are they active. Therefore, both things are told in the book. Can you see the slide now changed for you?
Yes, sir.
Okay, now we'll go to the next one. It's a little confusing there. Okay. Has it changed for you?
No, sir.
I read the question you get by the time. Which of the following is not characteristic of memory B cells? Rapid proliferation upon read it.
Which of the following is a not characteristic of memory B cell? Rapid proliferation upon re-exposure, long-term survival, immediate IgM secretion, differentiation into plasma cell. Differentiation into plasma cell.
It differentiates into plasma cell, is it not? Only after different B cells will proliferate, differentiate into plasma cells and then produce the antibody, both in primary and secondary response. What is the type of, see, you must, when you read a multiple choice, you have to be very careful, both in the stem as well as in the answer. Immediate IgM secretion, is it IgM? The memory B cells are in secondary response. Read it now.
Yeah. On secondary antigen exposure, memory B cell readily proliferate and differentiate into plasma cells secreting large amount of high affinity antibodies.
Secondary response is IgG, primary is IgM, okay? That you should know. We have already said this. I am again and again bringing it about because it shows memory B cells are generated in response to, I think it has not changed for you. As the diagram come?
Yes, sir.
Sometimes it comes.
Come.
Okay. Memory B cells are what happened? Memory B cells are generated in response to T-dependent antigen during in parallel to plasma cells. And anyway, whatever it is, the memory B cells produce a lot of IgG, not IgM. Okay, we have gone through this several times. Now, what's the next question?
Which type of the vaccine mimics natural infection best? Conjugate, inactivated, live attenuated, subunit.
Now, what's the delay?
Live.
Okay, live adenovirus. Okay, read the answer.
Live attenuated is an excellent immune response as they mimic a natural infection.
Read it.
What is the recommended minimum interval between two live parenteral vaccine if not given on the same day? 4 weeks.
Okay, it is a 4 weeks for killed. It is for the same antigen is 4 weeks for killed. But in killed vaccine, you can give a margin of 4 days. You can give before 4 days. But live attenuate vaccine, the minimum has to be 7. It has to be 4 weeks. Okay. Read the answer.
They should be given at least 8 days, 4 weeks apart.
Okay.
Which factor contribute to the reduced effectiveness of subcutaneous injection compared to IM?
You are having a not only the slides are not changing, the answers are not coming. Yeah, see, the lower dendritic are there because lower vascularization. Only if the blood supply is there, dendritic supply will be there. Okay.
They have a fever in adipose tissues such that subcutaneous injection may be less effective than intramuscular injections.
Read. It's a change for you.
No, sir.
Secondly, the site of administration of killed vaccine is of importance. The intramuscular route, which is well vascularized and has a large number of patrolling dendritic cells, is preferred over the subcutaneous route. Now, I want to tell you, I told this to Gopika also. I'm telling each one of you to go to the immunization clinic. When ask them to call you when they come, the patient comes for BCG vaccination. See how they are giving the BCG. It's not that easy. See, it is if you become a pediatrician and you don't know how to do what you call I mean even a lumbar puncture or a bone marrow, it may not be that problematic. But if you don't know to give an intradermal injection, it's not easy. It's not easy in a child. BCG given subcutaneously, one, it may not be effective. Two, it may produce lymph nodes. BCG lymph nodes may be produced. Therefore, in fact, you should learn under supervision of the nurses to give intradermal injections, especially IPV. But a fractional IPV is not given in our place. When you go to a health center, you might find a new nurse who may come and say, Doctor, today I'm posted. Yesterday I was in the labor room. I don't know to give intradermal. You must know to give intradermal injection. Okay. Okay, now read the last question. Has a slight change? I'll read the question if you get the answer. Which of the following vaccines can be repeated if given earlier than the minimum interval? Rabies, hepatitis B, DTP, and MMR. Hello? Rabies. Actually, do you know the reason why rabies is given, though it is considered as a kill? I was going through it carefully. What is the immunological basis which rabies we are giving 0, 1, 3, 7, 14, 21, 28, like that? What's the basis? I couldn't get an answer to it. It's not a live viral vaccine, cell cultured vaccine. I think it's a killed virus vaccine, but still we are giving it in short intervals. Anyway, I couldn't find the answer to it. Okay, read it.
This rule does not apply to
Yeah,
live and parent vaccine. Rabies is exception.
and there's an incomplete answer. But if you read the what is given in the bracket here, the minimum interval between two doses of inactivated usually 4 weeks, exception being rabies. The vaccine dose administered up to 4 days before the minimum interval or age can be counted as valid, exception rabies, except. Therefore, this is very important. You should also know the minimum interval. Why should you know the minimum interval? Because people are traveling. Therefore, they would come and say, Doctor, we want to go abroad, or we are going to the Gulf. The child is going during holidays to be with his father in Gulf, and he's traveling 2 days before his due date. Can we give it or not? Killed vaccine? Yes. Live vaccine? No. That's the answer. 4 weeks is a must. Remember this. Killed vaccine up to 4 days before that you can give. Before that, fifth day before you shouldn't give. That's the rule. That the best thing to do is what I tell them is then they will become very upset. What to do, doctor? There is a minimum interval. There's no maximum interval. Therefore, I would say go and come back. We will give the vaccine at that time. The only risk is he might develop an infection. But then there's no other answer. There is minimum interval. Remember, there's no maximum interval. We don't want to give a maximum interval because he may get the disease. It is better to postpone the vaccination when the minimum interval cannot be maintained rather than give it within that time. Okay.
What is the primary effector function of IgA? Protection at mucosal surface.
Okay. Read through it.
Live oral or nasal vaccine induce serum IgA and secretory IgA, which also help limit viral shedding on the mucosal surface.
Okay.
What is the primary mechanism of protection provided by glycoconjugate vaccine?
Rather twisted question, but you must be able to answer it. This I said this is a rather this one, the glycoconjugate vaccine. We said that conjugate killed vaccine do not prevent colonization, sterilization. I also said there is the opposite view. What's the opposite view? Opposite views, they prevent colonization. Therefore, there's a little controversial. I will not say they prevent colonization, but it's given somewhere in the book, it seems. But achieve glyco, which may prevent nasopharyngeal colonization. In fact, if you read pneumococcal vaccine, one of the advantages they say is you give it to the patient, it protects the child 1 to 5 years or maybe a little older than that. But there is, it transfers, it protects the majority, 5 to 70-year-old people in the family. It has been found out that especially senior citizens, they don't develop pneumococcal pneumonia once the child is immunized. Therefore, there seems to be nasopharyngeal local protection because they prevent colonization to a certain extent. But there are two opinions as I've already discussed. Okay. But I put back the same question. I put back the same question which I did last time. That is question number 20. From question 32, we are just telling you how they say it is live oral vaccine. We have seen live oral vaccine, but here they are telling conjugated vaccine also. Okay. Now let's read something about it. Okay. Can you read it as it changed?
Under most circumstances, inactivated vaccine do not elicit sufficiently high and sustained antibody titers on the mucosal surface to prevent local infection. It is the only after having infected mucosal surface that pathogens encounter vaccine-induced IgG serum antibodies that neutralize virus, activate complement cascade, and limit their multiplication and spread, preventing tissue damage and thus clinical disease.
Okay, there's one thing he says that the conjugate, this is Plotkins. Therefore, the questions are usually based on your book. Okay. Can you read? Has it changed?
Current vaccine mostly mediate protection through the induction of highly specific IgG serum antibodies. Live oral nasal vaccines such as rotavirus, oral polio, nasal influenza, or cholera vaccine induce serum IgA and secretory IgA, which also help limit viral shedding on mucosal surfaces.
Okay. uh, the top, they have written the vaccines fail to induce sterilizing immunity is not an obstacle to successful disease control, although it represents a significant challenge to the development of specific vaccine against chronic viral infection. I didn't understand that. But whether conjugate vaccine reduce colonization, they are talked in two ways. Lastly, last sentence. Has a slight change for you?
As a rule,
Yeah.
yes, sir. As a rule, such responses are not elicited by polysaccharide bacterial vaccine, but achieved by glycoconjugate vaccine, which may prevent nasopharyngeal colonization or non-bacteremic pneumonia in addition to invasive diseases.
So Plotkin is very clear that conjugated vaccine prevents colonization. But then in one of the questions they have asked that it is a live oral vaccine like oral polio or nasal influenza, which is more effective. But colonization are also plus minus prevented by conjugate vaccine. Now, next question, please.
Which of the following is true regarding secondary immune response?
Okay.
Higher, faster and higher IgG titer.
Okay. There's a lag period, but still I think the answer is right. Okay.
Secondary immune response start.
Yeah.
Subsequent exposure persists for time, mainly IgG type with high antibody titer.
Next.
What is the significance of extrafollicular B cell activation? B cell generation.
There's a lag period. What is the lag
What is-
period? Answer this. We have discussed it today. Where are the others? Where's Gopika?
Yes, sir.
Yeah, you're sleeping. Answer. You're not coming to the help of Amal. Early low affinity IgM response, is it not? Read it.
In primary immune response, the antigen exposure elicit an extrafollicular response that result in the rapid appearance of low IgG antibody titer.
I don't know how many times I should come back to this diagram. Again and again, I come back into this because in the primary response, it goes through here. It enters the germinal center, but the germinal, can you see the diagram? Has it changed?
Yes, sir.
Okay. In the
Yes, sir.
primary response, it comes here, B cell, plasma cell, IgG, low affinity, goes into a blood. It enters here. This is the same thing that happens in pneumococcal vaccine. It's only in the extra germinal center. But it in new polysaccharide vaccine cannot enter the germinal center, but conjugate vaccine does enter. But in the primary dose, it enters, it produces what is called as the germinal center, but the germinal center may take 4 to 6 months for it to get produced. But it produces two things, cells. One is high levels of IgG, which are clonal proliferate, therefore they are more specific. And therefore they go into the blood, they go into the bone marrow, and therefore that we have already led. Along with that, it produces the memory cells. Therefore, this again, you remember this. This is the memory cells. For what was the question? Which they produce along with the IgG antibody, it produced the memory cells. Therefore, the question here was, what's the significance of extrafollicular activation? It is low affinity IgM response. See, the primary response we know is IgM. This is the secondary response they are talking of, protein antigen. Primary will be IgM. Secondary will be IgG. And it will be extrafollicular primary. Okay? I hope it's clear to you. Now, my question here. Carry on. Can you see the slide?
Which vaccine type is associated with primary failure? Inactivated.
Can you help? This is after for nearly. This is after nearly, I think, 8 or 10 hours of bombarding you with immunization, immunology, primary failure, and having uploaded the file. You are telling which vaccine?
Diabetes.
Okay, read it.
The take of live vaccine is not 100% with the first dose. Primary failure, hence more than one dose is recommended with most live vaccine.
Let me tell you one thing. See, actually, the live vaccines don't require boosters because they keep on multiplying, that they produce a primary and the secondary immune response. Now, what they say is, example, measles. Why are you giving the booster dose? You're giving it 9 months. We have already said that the maternal antibodies are the viral vaccines, live viral vaccines are exclusively sensitive to the maternal antibodies. That is more than the bacterial kill the vaccines. That's why we are not giving measles up to 9 months. Even at 9 months, they are not giving in Western countries. They are given at 1 year. Some places give at 15 months. But in India, what happens is many children develop measles in the first year itself, and they develop severe measles. Therefore, for that reason, we are giving it 9 months. But we give another dose at 15 months. Similarly, varicella, we may give one. Why are we giving it at 9 months and giving it 15 months? The primary first dose may not take. Because if there are we are giving because we are afraid that the child may suffer measles. We are giving a booster because we think the antibodies may have been present in the vaccine, might have been neutralized. This is called primary vaccine failure. But mainly we were talking about this for patients with oral polio. Now they have started talking about it for parental injection also. Remember, varicella, we give the first dose at 15 months, and within 2 months, we will give another dose also, because you think if there is varicella antibodies, it may not get protected. Can you read it? You have to read through it. Has the slide changed?
Live vaccine induce an immune response similar to the seen with protein vaccine. However, the take of live vaccine is not 100% with the first dose. Primary failure, it's more than one dose is recommended with most live vaccine.
We read through the next rest also. It's important.
Once the vaccine has been taken up, the immunity is robust and lifelong, or at least for several decades. This is because of continuous replication of the organism, that is the constant source of the antigen. The second dose of the vaccine is therefore mostly a primary vaccine failure, no uptake of the vaccine, and not for the secondary vaccine failure. decline in antibody over time. However, mumps does not follow the general principle. Waning antibody level have been demonstrated, therefore, the need for subsequent doses.
Okay. Now, why do we give boosters for others? We give DT at 5 years. We may give it at TDAP at 10 years. Why? Because these were killed the vaccine. The boosters are given to produce a secondary immune response. In live vaccine, theoretically, secondary immune response is produced even from the one vaccine because it's multiplying 6 weeks later, 10 weeks later, 3 months later. The live attenuated vaccine is there, it's multiplying more antigen. It produces both the primary and the secondary response. But still, you give booster doses because not because the antibodies wane, because the first dose you gave may not have been effective, especially in measles at 9 months. Where is the lad 15 months? But this is not absolutely true. In Western countries, in that case, then what will happen is if you give, for example, a measles at 15 months, it produces antibody. You can just not give the booster. If you can measure it, you need not give. But that's not the fact. In Western countries, there are epidemics of measles occurring at 10 years, 15 years, etc., which is more dangerous because, if rubella also occurs, it produces congenital anomalies. Therefore, they are giving booster doses because of waning of antibody. But for your sake, please remember that the case why we give in live vaccine is because of primary failure. And for the killed vaccine, it naturally requires booster because the first vaccine will only produce the primary response, which is not enough, and it will produce memory cells. You have to booster the memory cells by giving a second response. Therefore, there's a difference in what's the time now there? It's 5 o'clock. 5 minutes are there.
Yes, sir.
Yes, sir.
Huh? This is a little tricky question. Can you read it now? For last question, we'll read this and stop it. Okay.
Cytokines are stimulated by BCG, leading to non-specific immunity.
Which cytokines?
TNF alpha and IL-6.
IL-6, huh? I don't think that's the answer they gave. I didn't find it anywhere. Okay, read it. It's given alpha, IFFN alpha and IL-2 there. I think it's something wrong with the answer in this. Read through it, read it, and then we'll read the explanation also.
When given BCG respond with T helper cell 1 and T helper cell 17 response, and their stimulated monocytes show increased receptor expression.
That's not the answer is not there in that question actually. Anyway, we will discuss about it next time. Okay, we'll stop it here. This question is rather ambiguous. I also felt the question is ambiguous. We have finished 70 questions out of, we have finished, how many slides? This is question number 36. We have 14 more questions. And next week, I will go into discussion of certain vaccine which we did not discuss, like meningococcal vaccine, rabies, and few other immunology of them. And subsequently, we will go into preterm immunization, catch-up immunization. These are very important things. Any questions you want to ask? Anju, you are there?
Yes, sir, I'm here.
Yeah. Any comments you want to pass?
No, sir, nothing at all, sir. A lot of things to study from your class. So probably I will be waiting for the upload also, sir, because many things I have to reread and.
Yeah, you are the only person
we have
who
to
are
study.
rereading. None of the students are reading itself. Forget about the rereading. These
No, I
questions.
have not finished the first.
Actually,
I have not finished the first episodes.
yeah, for this question which I asked this time are all from the previous this one. Had
Yeah.
uploaded it also and they didn't pause. Now I'll stop the recording anyway.
Okay.